Well, thanks, Alan, and your colleagues for inviting me here. It's a real honor. I feel as though I should start off by saying that my name is Tony Delitto, and I haven't done a randomized trial in 3 years. but but actually, that would not be quite truthful. We are doing one now and planning one, but I will tell you this, that I did shift my emphasis quite a bit in my research career from doing the efficacy, effectiveness types of studies to actually trying to do or attempting to do implementation studies, and then trying to demonstrate the fact that that I think the real challenge for us now is in the implementation area. And that's what I think that's why I'm up here, to talk about my experience in that. I had a revelation in around, it occurred around the late 1990s when I had the attitude going into doing research in this field that if you built it, they would come. If you built an evidence-based practice, all you had to do was publish the work and it would work. It would happen magically in the clinic. And I found out the hard way that the real task ahead of us is getting things implemented, and that's what my research has been around. Alan talked about where I'm from at Pitt, and right now we're in the midst of trying to take advantage of some of the reform opportunities that are out there. And what we've really I've centered my attention around is this value and the importance of demonstrating value. And I need to put this up front because this is really what's driving what I want, my research and the direction of my research. And I think it really does provide research directions for all of the rehab professions that are in the room. And I think, as we've heard earlier now, it's more than just effectiveness for all, but I think we have to, I truly believe this very strongly, we have to broaden our perspective, and we have to identify the patients where we are the most valued. And I think that it gets to the question earlier about prioritizing. And it's a little bit of a different way, and it also leads me into this diagnostic research component. Because a lot of the work I had done previously in the area of classification of low back pain is related to doing diagnostic type studies or using a diagnostic process. Now, Alan, as I said earlier, spent a lot of time telling you about all of my roles at the University of Pittsburgh. But in reality, what I'm going to be talking about are really my roles outside of the university and within our health system that we have created at the University of Pittsburgh, namely this 400-pound gorilla that we have called the University of Pittsburgh Medical Center. And we are what in the reform world is called a integrated financial delivery system. And it's very interesting. When you create a system like this, you begin to start actually being able to implement the kinds of things we've talked about. And I think until we create systems like this, we have too many competing issues going on that make it much more difficult to do implementation types of research that are based in value. The two areas that I want to focus on are, I have a role in the Centers for Rehab Services, which is the largest physical therapy and occupational therapy and speech therapy provider for the UPMC. Now, the University of Pittsburgh Medical Center has 55,000 employees, 8 acute care hospitals, and we have 42 outpatient clinics, 4 specialty programs. We have APTA credentialed residency programs. We have over 300 therapists. It's a large integrated system, and we are the provider for this, the rehab provider for this integrated financial delivery system. It's very important to understand that. Once we're networked, we are much more easily able to implement some of the initiatives that we put forth. We also, I think the real other key player is our payer. We have a health plan. So suffice to say that in the old days, when it was run up the bills as much as you can and charge the insurance company, when you put a system like this in place, you now begin to realize you're taking the money from the left-hand pocket and putting it in the right-hand pocket. And you really can much more seriously discuss reform, efficiencies, and what's best for patients. So I'm going to talk more a little bit about diagnosis, and traditionally this is the traditional diagnostic study. over here. You have study participants, they come in. We have a target disorder that traditionally most people look at as identifying some kind of disease. Then we have tests that are positive or negative, and we look for true positives and true negatives, and of course we want to minimize these false positives and false negatives. And we have all sorts of statistics we can run on these kinds of tests that tell us. And then we have good studies where our reference standard we're blinded. There's all sorts of things that go on in studies like this. And what I'd like us to do in this, for the purposes of this discussion, is to start to think about refining what we call our target disorder or our reference standard. Okay? And if we refine this, we can take all of the diagnostic study techniques that we use and use them to our advantage. And I'm going to try to relate to you how how I believe this relates to comparative effectiveness research. So sometimes that target disorder can be responsiveness to certain interventions, and this is what we learn as clinical prediction rules, and we've found this to be a very effective means of identifying treatments where patients are responsive, or we identify characteristics of patients who may be more responsive to certain treatments than others. This has been especially effective in the area of low back pain, where there really isn't much else to guide a person in terms of treatment. So, and the other area that I like to focus on is sometimes the reference standard can begin with just simply the simple question, who are our costly patients? And what sorts of factors predict who is going to be a costly patient? And for example, we know in back pain, less than 10% of the people that we see, at least from studies that are out, are responsible for 80% of the costs of what goes on in back pain. So perhaps we want to look at this as a target disorder and through some sort of diagnostic process, try to see if we can predict beforehand who the more costly patients are. And those are two examples, and I'll go through some specific examples of how we've looked at that in our system. Well, I don't need many slides to convince, I hope, people in this audience to know that back pain is very expensive. And it's inordinately expensive, and for the most part, people will have asked the question, why do we need to spend so much money on back pain? I think it's very clear. These are numbers this is a 2010 estimate, and we see this less than 5%, 75% of the cost. Usually, no matter what study you look at, it's a low percentage of patients who are responsible for a high proportion of the costs. Now, it's no different with us, and it's especially important that you realize that on my role in the health plan, I'm part of a musculoskeletal subcommittee. And it's very important that I bring to the table my knowledge of research and epidemiology and everything else, but I really don't need to, because they look at their own data and the health plan, and they realize that, wow, low back pain is costing us a lot of money. It cost us $6.2 million on just 937 cases in 2009. That is a disproportionately large amount of money. It's the third largest cost bucket in our payer, behind neoplasms and cardiopulmonary disorders. So when you think about this, again, these are insurance executives and health economists who work for our health plan who come to us because it's a provider-led health plan, and they come to us in my role in the musculoskeletal subcommittee, and they ask a simple question: why are we spending this much money on people with back pain? A lot of these people are our own employees. So it's a problem across the U.S., and if I were writing an NIH grant, I would use this. But in my role in the health plan, it's a mirrored problem there. So we asked the question, well, where is the money being spent? And again, there's congruence in what's happening across the country, as well as what's happening right under our nose in our own system. Okay. Unnecessary imaging, a lot of procedures, excessive pharma, and I can pick on all the other professions here, but I'll also pick on my own profession. Not adherence to best care standards in our own environments. So we have excessive use of physical agents, passive agents, and things like that. We actually, in our system, are guilty of this. So when we look at our data, we see this, and so there's a lot of room for improvement here. And I'll put to you in this audience, we could have evidence-based practice courses until the cows come home, and bring every one of our therapists in, and we can turn around and test them all, and they'll tell you they have the competency to understand what's out there. yet we'll still see this behavior. And I have my own opinions of why this happens, but the major one that keeps coming to the front is the finances aren't aligned. That's the bottom line. And you need not look any further than the Medicare fee schedule, and you'll see. There's 5 different ways to charge for those passive modalities, right? Now, if we define our reference standard and redefine it, right, to this upper 25th percentile of costs, we can now begin to look at our data a little differently, okay? And I want to focus on 2 ways of looking at it, okay? One is what variables predict the upper 25th percentile of costs within our rehab environment, and then what are the external factors that predict these costs, okay? And it's very simple for us. With us, when we looked at our costly patients and we looked at the internal factors within rehab, we looked at a simple question of, does adherence to best care standards in the rehab environment predict the upper 25th percentile of costs? In other words, when we provide decent care, or what we would consider on-protocol care within our physical therapy environment, right, and compare that to when we don't provide it, this is taking advantage of our bad behavior, okay? We actually look at when we have provider care that's not up to standard, does it predict that upper 25th percentile of cost? Okay, and this is one way to look at a diagnostic study. So, and the other way of looking at it is, because we can combine our information with the data that's available in other places, what are the comorbidities that predict these upper quartile of costs? In order for us to do this kind of work, right, we have to create the database ourselves within the intra-rehab environment. That doesn't exist. It didn't exist before. So, I don't know what's happening here. Okay, but anyway, so what we have to do is formulate this clinical database, and we formulate it based on evidence-based practice principles, okay? We have to collect this over a period of time, and we have to make sure it's very comprehensive. We can't be accused of cherry picking. And we have to then evaluate our therapist's compliance to putting the data in the database in a complete format. Their adherence to best care standards, we have to define what those best care standards are and see if they're adherent to them, okay? And then we also track outcomes. We would like to do a better job of this last piece, but that's a work in progress. But for these first 2 pieces, over a period of a couple of years, we've been able to do this. We've been able to get data. We identify ICD-9 codes that relate to low back pain. We make sure that our therapists are over 95% compliant. Every time we get a patient who comes in with one of those ICD-9 codes, we get a completed data set on this minimum data set, okay? We then have come up with algorithms where we look at adherence to best care standards, and we look at non-adherence to best care standards. And then we can go to our health plan and see what kind of prediction value some of this on-protocol versus off-protocol status has with regard to predicting upper 25th percentile of costs. This is one of the pieces of information that I like to say, take care of our own house. Provider adherence to best practice and measurement of provider performance is one of the intricate variables that we need to look at when we're trying to show value. So it requires rehab process of care data, adherence in the trenches. It's more than claims data. Claims data is meaningless here, guys. You can't really get into look at this in a granular way with just claims data. And it's an opportunity. It's also an opportunity for us to help design electronic medical record components that we are going to need. So is protocol adherence a strong predictor of unusually high costs? Well, we look at this in a very standard diagnostic process approach. We look at, as I said before, our adherence is based on algorithm-based rule sets, and we do this very, standard approach that you would do in a diagnostic study, okay? And the answer is yes. A non-adherent care is 1.5 times more likely to end up in the upper 25th percentile of costs. And immediately, the evidence-based practice people in the audience are going to look at this and say, whoa, look at this confidence interval here. I don't know about that, you know? And you're right. You know, from a strict adherence to evidence-based practice standard, you'd say to yourself, well, I don't know if that's really enough. But I have to ask you guys, what's the threshold for action here? You know, and the threshold for action as far as our health plan is concerned is, yeah, it looks pretty good to me, because when we also did some other analyses and we looked at adherent versus non-adherent care, we found that non-adherent care ended up costing us about $250,000 more downstream after the person left PT. As far as the threshold to action for our health plan was concerned, we met it. As far as the threshold to action for others, you know, it's debatable. Now, what about other rehab factors? Well, it seems as though I put diabetes and obesity up there, because when we have somebody who sees us with low back pain and they also present with diabetes and obesity, they are 10 times more likely to be in this upper quartile percentile of costs. And in this situation, you have to trust me when I say that these are low back pain related costs. This is in addition to all the other costs these people, these two comorbidities lead toward. All right. So again, a threshold to action here, it gets us thinking, what should we be doing in the rehab environments? So I think what we're driving at, what we're trying to drive at is, this represents the total amount of money that we are dealing with. We have a good proportion of this procedures, a good proportion of it imaging, a good proportion of drugs. These three areas we know we're overutilizing, right? And we have these rehab charges that are here. We actually have made the case that we may want to increase the amount of money we're spending in rehab on patients, but only if we're going to decrease, if it leads to decrease in these other costs, okay? And in order to do that, we have to make the case that we're going to clean up our own house. In other words, if people are going to divert patients toward the rehab environments, then it would be much more effective in our argument if we were to say that we are more adherent to best care standards. And I think this slide there's a few points to make with this slide that I think get to the crux of the issue. This circle does not represent money. This circle represents encounters, okay? Every time a person with back pain sees someone, that's an encounter with someone. Or every time they utilize a service, that's an encounter. And right now, the physical therapy component is a smaller piece of this pie, and most of the larger pieces of the pie are everything else, everywhere else they go. And the idea is to shift the encounters, increase the piece of the pie, and again, we're relatively inexpensive compared to these other things. And of course, while we're shifting people to this component, we are putting in place procedures that better assure adherence to best care standards. And the thought is that there would be less encounters with these other more costly procedures. So this is an inexpensive way to go. There's a quality component to it, and it really does define the role of evidence-based practice and what it is we're doing. Okay. Now, encounters, what we think has happened in the past and what's happened in our experience in the past is that the attempt to try to decrease encounters itself, which is what a lot of guidelines have advocated since the mid-90s. Don't do this. Don't send them here. Don't do this. Back pain will get better on its own, right? What we realize is that as soon as you give the patients, that approach may have worked if the gatekeeper component worked, and if the primary care physicians truly could be gatekeepers. But what we realized was that patients don't settle for that. And as soon as you give patients expanded choice, they won't listen to someone who says, you're going to get better, don't worry about it. They're going to go somewhere else, and this is what they've been doing. And again, we can track our data to see that. You know, a very large percentage of our patients, within a week of seeing their primary care physician, were off seeing someone else. And this is what happens. We had adherent care on the primary care physician's part, but we didn't have it wasn't working with us in our system. So this is I think encounters becomes the key here. Because when you decrease encounters, that corresponds to rationing. And when you can keep your encounters up, and you're likely to keep the satisfaction of the patients higher. It also points to another area that I think is important, and the other area is this notion of, we were just talking about it, the interprofessionalism and the role of these advanced practice professionals and the acceptance of advanced practice professionals as a solution to some problems within the system. And I think that's another thing we struggle with in our system. So that's my talk.